Good evening, and welcome to another episode of NMA Talks, brought to you by the National Medical Association, the nation's oldest and largest organization of African American physicians, focused on diversity in medicine and justice and parity in health. I'm your host, Dr. Michael G. Knight. I'm an internal medicine and obesity medicine physician at the George Washington University School of Medicine and Health Sciences here in our nation's capital, Washington, D.C. And we are so excited to be together for another episode focusing on what? On obesity, particularly in the African American community. We know that it is National Minority Health Month, and we want to jump into this topic as we always do. We bring you the leading voices in health, and particularly leading experts in African American health. And now I'm going to introduce our panelists for tonight. First, we have Dr. Fatima Cody Stanford, who is one of the first fellowship-trained obesity medicine physicians in the world. She is an obesity medicine physician scientist at Massachusetts General Hospital and Harvard Medical School. She serves as a director of diversity for the Nutrition Obesity Research Center at Harvard. And you can find her on social media at Ask Fatima, Dr. Fatima. Welcome, Dr. Cody Stanford. All right, let's now go and bring in Dr. Johnson. Dr. Shaneeta Johnson is the director of minimally invasive and bariatric surgery at Morehouse School of Medicine in Atlanta, Georgia. She's board certified in surgery and obesity medicine. She's a fellow of the American College of Surgeons and American Society of Metabolic and Bariatric Surgery. She's also a senior fellow of global health equity at the Stature Health Leadership Institute and president of the Georgia chapter of the American Society of Metabolic and Bariatric Surgery. You can find her on social media at smjohnsonmd. Welcome, Dr. Johnson, to tonight's show.
Thank you for having me.
Thank you. And finally, last but not least, we have Ms. Kesha Calicutt. She's an international health advocate and speaker. She is a dynamic educator specializing in special education and a passionate health advocate. She's a founding member of the Obesity Action Coalition's Diversity and Inclusion Task Force, a disease experience expert panel member with Novo Nordisk, and a member of many professional educator organizations. When she isn't jet setting around the globe, spreading the word about equity in healthcare, you can find her making music for her students, hiking with her family, or schooling her two disobedient step dogs. Welcome, Calicutt, to the show tonight.
Hello.
All right, so why are we even talking about obesity in the African American community? We know that obesity is a chronic disease. It is a complex disease that requires comprehensive care. And of course, I may have a little bit bias as also being an obesity medicine provider, but I think one of the most important things is understanding that in the African American community, we see very, very, very high levels and rates of obesity as well as overweight. And we're going to jump into what those words mean and what treatment actually means. We know that African American women have the highest rates of overweight and obesity compared to other groups in the United States. About 4 out of 5 African American women have overweight and obesity. And in 2018, non-Hispanic Blacks were 1.3 times more likely to have obesity as compared to non-Hispanic whites. And we know that there are so many more statistics. Unfortunately, it seems like our community is always at the bottom of the barrel when it comes to many of these things. And I don't think it's because we want to be there. Dr. Fatima, why don't you open us up and let us understand, why do we continue to see a growing trend of overweight and obesity in the African American community?
So first of all, like I said, it was a delight to be here tonight. And I think one of the key issues that you bring up, Dr. Knight, with regards to this complete proliferation of obesity within our community is a lack of understanding that it is actually a disease. Many people think that this is a lifestyle choice, something that you brought upon yourself. And when we continue to think of obesity in that way, we will continue to, see this proliferation. We know, like you said, obesity is a complex multifactorial disease where genetics, development, environment, and behavior all play a role in a person's likelihood of having this disease. And we have some complex issues that really cause this to be an issue within the Black community. For example, racism, which is unfortunate within our community, predisposes someone to a higher risk for having obesity. We know obesity is a chronic disease associated with inflammation, and racism can cause inflammation. In the Black Women's Health Study, we saw higher rates of obesity in those that experience both everyday and lifetime racism. So the factors that affect our higher prevalence of obesity are vast. Unfortunately, we do have narrow definitions which constitute how we look at obesity. We look at something called body mass index, which then, dictates where we fall. A person who has a body mass index between 18 and a half and 24.9 has what's considered to be normal weight status. A person has, overweight with a BMI of 25 to 29.9. And then we get into obesity, a BMI greater than or equal to 30. And we have class 1, class 2, and class 3 obesity, or mild, moderate, and severe. BMIs of 30 to 34.9 being mild obesity, 35 to 39.9 being moderate obesity, and those that have severe obesity, BMIs greater than or equal to 40. Now, I like to use other tools to evaluate weight status, which include waist circumference. So our target waist circumference for the men and women that are listening tonight, when a measure at the umbilicus, which is a fancy word for belly button, you want to have a waist circumference of 35 inches or less as a woman and 40 inches or less for men. And so I like to couple these things together because it's not just about the weight itself in the BMI chart. Keeping in mind the BMI charts were formed without necessarily us as Black folk in consideration, but also taking into account where that adipose or fat tissue is distributed. So there's so much to go into, but I hope that sets us up for some good discussion tonight, Dr. Knight.
Oh, definitely. Thank you, Dr. Cody Stanford. And let's now turn to Dr. Johnson, because one of the things that Dr. Stanford outlined so clearly is that obesity is so complex and involves many other disease processes. And when we think of high blood pressure, diabetes, Dr. Johnson, can you talk a little bit about the effects that obesity has on other health systems and why this has to be a focus for our health prevention and execution when we think about achieving optimal health?
Right. So as Dr. Cody Stanford has mentioned, obesity is a disease. And unfortunately, it is a disease that is related to the development of many other diseases that we see very commonly in the African American community. We're talking about diseases like hypertension, cardiovascular disease, stroke, diabetes, sleep apnea, and even the prevalence of certain cancers such as endometrial cancer and breast cancer and colon cancer have been associated with higher levels of obesity. So on top of dealing with one disease, we are talking about the prevention and or treatment of many other diseases when we talk about the treatment of obesity.
Thank you, Dr. Johnson. All right, Ms. Calicutt, I'm going to bring you in here because one of the things that we know as an advocate for health equity, we get sometimes frustrated when we continue to see disproportionate impact of disease processes in the African American community. Can you talk a little bit about what are some of the barriers to achieving health equity in this space?
Well, one of the things that I like to speak to, and I use myself as an example, I like to say that my obesity is in remission. It's a lifelong disease, which needs lifelong treatment. There isn't a one and done fix for any of this. But one of the reasons that I'm able to manage it in the way that I do is because of the privileges that I have. I have a family. They will eat whatever I cook. If we're having salads, that's what we're going to have. Nobody complains. I have the privilege of having a warm, accepting home that is going to adapt to the needs that I have to manage my medical condition. Expensive. It's really expensive to eat healthy. I could get a $7 salad at McDonald's, or I could get 7 McDoubles. And when you're looking at having to feed a family, sometimes you have to make those hard choices. But because I have economic stability, I have the privilege to be able to make those choices. And when we're looking at people, well, why can't you do this? Why can't you do that? Or why shouldn't you? I don't know that most of us are taking a comprehensive look at what exactly it takes to manage a lifelong chronic disease.
Excellent. Thank you. Thank you for outlining that and also for sharing some of your own personal experience. I think we are excited tonight to have not only health experts and clinicians, but also individuals who have been on the patient side. So we appreciate that perspective. You know, Dr. Stanford, I'm going to come back to you, and I see some folks have already started putting questions in the chat. We encourage you to do so. We have a question about the methods that you use to identify obesity in your practice. And let's get a little bit more specific. When we talk about obesity, you talked about BMI, you talked about waist circumference. What are we talking about here?
So first of all, it's important for us to recognize that obesity is an actual disease. And so I really want to make sure that if you guys get nothing else, that you get that from tonight. So what do we mean by that? Like, why is it called a disease? Why do I keep referring to it as that? A disease means that there's pathophysiology, things that are going on in the body that cause us to eat more or store more, or eat less and store less. And the most important organ that we need to bring to light in terms of how our body regulates weight is indeed our brain. So the brain is getting signals from our fat tissue, from our large intestine, our small intestine, our pancreas, our stomach is sending signals back to the brain to tell us not only how much to eat, but how much to store. And so it's not just a willpower thing. I can't send, I wish I could, send signals to my brain and say, you know what, I want you to signal that way. But that's not what it does. Now, there are different factors that lead to that idea that someone has a disease versus a not. And going back to that question that I saw that was being asked, is that we often do use these BMI cutoffs to categorize, obesity. But we also have to look at weight distribution. We can carry weight centrally, and by that I mean in the stomach region, what we call central obesity, around the vital organs. So if it's in the stomach area, it's around our liver, it's around our heart area, it's around a lot of important organs. Or, as very common in the Black community, we see it more carried in the hip, buttock, and thigh region. Weight that's carried there is usually not very problematic. It's around our bones or muscles, but not around any vital organs. And so we have to take those two things into account. The other way, if we were doing a deep dive, is looking at this idea of body composition. A lot of fancy tools go to look at body composition, but we can use simple measures. We can look at height and weight. Like we said, look at BMI. We can look at waist circumference, couple those together to give us a sense of, where weight's distributed, how much weight one's carrying. I hope that really answers the question, Dr. Knight.
I think it did. And I know we're going to talk a little bit more about that. But Dr. Johnson, I want you to come in here because, I'm sure many individuals who have been dealing with excess weight have gone in for their annual physical, for example, and stepped on the scale, and maybe they received a handout. And usually the recommendation is to eat less and exercise more. And so, Dr. Johnson, is that the only solution for excess weight? Can you talk a little bit about how obesity is actually treated?
Yeah, so unfortunately, you're right, Dr. Knight, that's often what we see as the only treatment for obesity. Thankfully, we have had a lot of advances in the field of obesity medicine. And so there is actually a spectrum that we have of treatment options for obesity. We have diet and exercise, we have medications, lifestyle modification, and surgery. And so I do weight loss surgery, which is on the latter end of the spectrum. This is typically for patients who are about 100 pounds over their ideal weight, or in that class 3 obesity that Dr. Cody Stanford mentioned earlier. And we find that the most effective treatment is a multidisciplinary, multimodal treatment for obesity, meaning we use all of the available options because this is a very, very complex disease that we are treating. And so the most effective treatment is to be working with your primary care doctor, with an obesity medicine physician, with a nutritionist, with a psychologist, and a surgeon, and maybe a few other specialists as well.
Thank you for that, Dr. Johnson. And it's so interesting. You talked about a psychologist, the mental health aspect. I'm going to go to Ms. Calicutt because I think sometimes we don't always think about how mental health may interact with obesity. You know, we think about how our excess weight might affect our mental health and also how our mental health may affect our weight management. Can you talk a little bit about that?
Yes. Um, I remember, there's an evolution, and as we grow and progress, hopefully we're all doing that. I would get really judgmental, like, how could you lose all that weight and then gain it all back? Like, life is so much better when you're able to move more freely throughout the world. When nobody's calling you a refrigerator just for simply existing and walking across a parking lot. But one day it struck me that if you have lived with overweight and obesity your entire life, waking up and navigating the world in a smaller body would be as shocking as me waking up as a white man tomorrow. There is a lot more privilege associated with being a white man. I don't have to worry about the police chasing me. I run a less chance of getting killed by the police. I can move freely throughout the world. But because all I know is the body in which I lived, I would want to go back to that, no matter how many other privileges the newer body afforded. And so it just kind of gave me an understanding. It's not just metabolic things that can push people back into obesity, but psychological as well, and not feeling as if they are part of their body.
Thank you for that. And thank you for sharing, your experience and what we have been seeing, as an internal medicine and obesity medicine physician. I often have conversations with patients who have spoken with other healthcare providers, who have spoken with family members who, have said, well, why don't you stop eating so much? Why don't you just get active? No one else, your siblings are slim. What's going on with you? And individuals have oftentimes, by the time they come to my office, have dealt with years and even decades of struggling with weight. Dr. Stanford, why is it such a struggle to lose weight?
It's all about this thing we call the weight set point. And so what happens is, going back to that lovely brain of ours, which, tells us, a lot of good things, but in this situation can be our own worst enemy. Our brain knows what our set point is. So let's say you weigh 300 pounds and you try to lose weight. And you're like, why do I keep coming back to 300 or 305 pounds? It's because the brain remembers that that's where you are. So let me kind of explain it this way. Some of us have different, kind of gas tanks, right? So if you have, let's say you weigh 300 pounds, your gas tank may be the size of a tractor trailer. And you want it to be more of a size of a mid-size sedan. But your brain is going to do whatever it can to compensate with all of those different changes that we said, to bring you back to making sure that gas tank, that tractor trailer size gas tank, is full, even though you're like, no, but I'm a mid-size sedan. That's really, you guys are laughing at me, but that's exactly really how I explain it to my patients. And I think it's because I was raised by my dad. He taught us kind of like boys. And so I think of everything in car terms and things of that sort. But I think it helps people understand why our body has this compensatory drive, this is what we call metabolic adaptation, to bring us back from whence we came. So for example, if we're talking about what Dr. Johnson does, surgical intervention, let's say someone does have 300 pounds. She is doing some surgical interventions. She's doing some laparoscopic or maybe robotic surgery, but what Dr. Johnson is doing more importantly is she's changing that brain-gut connection when she makes that cut, either for a bypass surgery or a sleep hysterectomy. She's actually changing that. And that's why we actually see that major shift in weight. It's not that we're just necessarily making something smaller or whatever. It's literally changing that connection. Similarly, with medications, we are acting on different parts of the brain to drive weight status down while using that medication. So it's amazing to be in the field at this time as we're continuing to learn more and more. But I like to for people to know the complexity of this and how our bodies desire to come back to that tractor trailer when you really want it to be a mid-sized sedan.
I appreciate that, Dr. Stanford, and giving that example. I often use example of like a thermostat, when it comes to this set point. I think just as you said, your mind, our bodies are very, very well designed. Okay. And, whatever your beliefs are of how it was designed, whoever designed it, it was well designed. And at the end of the day, our bodies don't always necessarily see excess weight as a problem. People will think, well, if I am overweight or dealing with obesity, then shouldn't my body want to lose weight? And they find that as a challenge when it comes to that. So let's kind of take it back. So maybe there's a patient, they have gone to their doctor, they have tried the diets, new year, new me has been an annual hashtag for them. How do you start the journey? And maybe Ms. Calicutt, maybe I'll pull you in here. Because many individuals may go to their primary care doctor or provider and say, well, I want to lose weight, and maybe that's not where the resource is. Can you talk a little bit about what options are there for individuals who want to start a successful weight loss journey?
It takes everything. It's not a one and done fix, regardless of what it is. If you have surgery, if you make lifestyle changes, it's a chronic relapsing condition. And I think it's important that we throw the relapsing in there. Even if you have surgery, it's not an inoculation against weight loss. It doesn't mean that life won't happen or accidents won't happen or middle age spread won't happen. That weight will continue to tick up. The thing about surgical and medical interventions is just that it starts a little bit lower. So instead of ticking up from here at 300, maybe you're ticking up from here at 225. And it's finding that balance between wanting to lose weight, to be healthy, but also accepting whatever it is that your body is going to do. As much as we like to think we have control over what our bodies do, we don't. And it's finding peace with that. I know that for myself, I would love to lose 20 pounds. But if I lost 20 pounds, the only thing that would really change is my dress size. I'm at a weight where I can navigate the world freely. I can hike, I can mountain climb, I can move and experience everything that God has put on this wonderful green earth. And I think that we need to shift the focus to health and mobility and not necessarily what size we are.
Thank you so much for that. Thank you so much for that. As we think about, patients may come into my office and say, Dr. Knight, I looked at that BMI chart and I don't want to be that number that's in the normal range, right? I like my curves. I like how I feel. And I say that's not your number. I'm asking you, what will you feel comfortable? Maybe it's just a 5 to 10% total body weight loss, which Dr. Stanford, Dr. Johnson, as we know, carries health benefits, right? And so that is a very, very important. Before we go into, because I want to start talking about treatment options, we have another question from the audience. And again, please put your questions in. We would love to have more questions from the audience, so please do that. This is to Dr. Johnson, and specifically talking about obesity in the Caribbean, particularly here is outlined in the Bahamas. We know that many and the other of the islands in the Caribbean, as well as other parts of the diaspora, are also dealing with obesity. Can you speak a little bit about that?
Yes, unfortunately, the Caribbean is not exempt from the same issues that we're dealing with as African Americans here in the United States. We do have a bit more of an outlook on a healthy lifestyle, but we don't have all of the access to treatment that we do here in America. That is something that is being worked on at the government level to have that full broad spectrum of obesity treatments available in the Bahamas. Some of the other islands are a bit more ahead, and they have already begun obesity treatment programs that are well established. But hopefully here in the Bahamas, here shortly, that will be the case as well. Thank you for your concern for the Bahamas.
Thank you, Dr. Johnson. All right, let's go into treatment options. So Dr. Stanford, I've been dealing with excess weight. My BMI is about 30, 32, 33. What are my options?
So this is a great question. So what I hear you saying, Dr. Knight, is this is a patient that's coming in with mild obesity. And when we're looking at mild obesity, there are a few treatment options that are available. Lifestyle modification, which might focus on diet quality, physical activity optimization, right? We want at least 150 minutes of moderate intensity physical activity. But for those that have obesity, our recommendations are more along the lines of 300 minutes of moderate intensity. You're like, what is moderate intensity? It means that you could talk during your activity, but not sing during the activity. So that's important. We can look at psychological interventions. And what was mentioned earlier is that using psychologists to address things like binge eating disorder, other things that may be contributors, night eating syndrome, night-related eating disorders. What that means, just to kind of give you a sense, if you wake up and you notice Oreo crumbs in your bed and you have no idea that they got there, problematic, maybe need some psychological intervention. Or if you get up at night, it's like 2:30 in the morning and you always get up at that time to make a sandwich, also problematic. So there are different things that may be contributors. In addition, we can use pharmacotherapy, which means medications to treat obesity. Now, key caveat, because I always have to say this to my patients, if we use a medicine and it works for you, it is a long-term commitment to the use of that medication. We are treating the chronic disease of obesity, as Kesha mentioned earlier. It doesn't just go away. We need to continue that therapy. I told you we're acting on different parts of the brain to drive weight down. And as soon as we remove whatever that perturbation is, i.e. the medication that we're using to drive weight down, it will creep back up to where it was prior to that time. So those are the treatment modalities that we would entertain for someone with mild obesity.
Thank you, Dr. Stanford. And now I'm going to Dr. Johnson, which is going to pull in one of our audience questions. So maybe we have a patient that's come in and the BMI is 45 and they have tried diet and exercise and maybe they've already completed 6 to 12 months of a monthly weight management program. What would be the process to undergo bariatric surgery? What are the risks and what is involved?
So bariatric surgery is typically thought of once someone has class 2 or class 3 obesity. So class 3 obesity, as Dr. Cody Stanford mentioned, is a BMI that's 40 or greater. And then class 2 is a BMI between 35 and 39.9. Now with class 2 obesity, typically the insurance companies require you to have one of these diseases that we talked about earlier in the show: hypertension, sleep apnea, diabetes, or some other obesity-related disease. Now, I said insurance companies because there have been a lot of studies that have shown that these surgeries are effective at lower BMIs. And so the hope is that we will be able to move that number lower so that we can begin to offer this treatment to others that need the treatment and are not quite at that level of obesity. The process is typically a long process in that the insurance companies typically require you to meet with the team for 3 to 6 months prior to surgery. During that time, we're doing lifestyle interventions. You're meeting with an obesity medicine specialist. You're meeting with a dietitian, changing your diet, putting into place healthy habits that we hope will be maintained after the surgery. You're meeting with a psychologist. This is a requirement of the programs. And the surgery itself is an overnight stay. So a lot of people think this is a surgery that you're in the hospital for a week or two. It's not. Most of the surgeries are either outpatient or you stay for 23 hours and then you're home. They're typically done minimally invasively because the risk of the surgery are also some of the risk of obesity. And so we want to make sure that the surgery is done in as short a time as possible and you're up and moving as quickly as possible. So some of the risks we talk about are clots that can form in the legs and go to the lungs, known as pulmonary emboli. And the longer that you are on the operating room table, the higher your chance of developing those clots. And also the longer that you're not up and walking, the same thing. So most of the time you are up and walking within hours of having the surgery done. And then the other risk is problems with the staple line. That chance is less than 1%, very, very minimal, because we always test and make sure that your staples are intact before leaving the operating room. Now, what procedures are we talking about? The main procedures are the gastric bypass, the sleeve gastrectomy, and the duodenal switch. Each of these procedures have some form of restriction with them. And then also with the gastric bypass and the duodenal switch, you have some malabsorption, which means you are taking in less calories, but you're also absorbing less calories with the gastric bypass and with the duodenal switch. Dr. Cody Stanford already mentioned that there are metabolic changes that happens with all of these procedures. And so we know some of the hormone changes that happen, some of the hormones that increase in their levels, some that decrease in their levels. But it is such a complex disease that we are still searching for all of the answers as to why the surgeries are effective. But that is typically the procedure. I say once you have surgery with me, you're my patient for life, because we follow you for life, looking at your nutritional status. And as Ms. Calicutt said, it's a relapsing disease. And so we need to make sure that we're on the ball. We may need to add in medications. We may need to add in different interventions to continue that maintenance of weight loss.
Thank you, Dr. Johnson. We have another question from the audience that says, we often hear healthy weight. Should we focus on BMI, weight circumference, how we feel, or how our weight affects other chronic medical conditions? And there's a follow-up that says, for example, a patient who may have class 1 obesity, but doesn't have any other medical conditions and doesn't feel they need to lose weight. Dr. Stanford, what would you say to that?
Obesity is a disease. We're going to go back to that. We often discount the fact that obesity is a disease. And we're like, oh, I feel well. People often feel well when they have diabetes. They may feel well when they have hypertension, right? High blood pressure. It's not just about how you feel, it's about that it's a disease. And unfortunately, what Dr. Johnson mentioned, what Ms. Calicutt mentioned, is that obesity leads to a lot of other issues. The problem is we don't address the disease that's causing the other diseases. We treat everything around it. We go around the block, down the corner, we'll hide under the table, and we forget to treat the key thing that's leading often to these issues. So in this situation, if you haven't developed those issues, great. But the likelihood is significantly higher. We know your risk of sickness and death are higher. We know your risk of having issues related to COVID, which has affected all of our lives, significantly higher. So if we know this, and we know this beyond the shadow of a doubt, why don't we treat the disease? The reason we don't treat the disease is because people have yet to still recognize it. It was only in 2013 that the American Medical Association actually acknowledged obesity for the disease that it is. But for my physician colleagues here, for Ms. Calicutt that's here, unfortunately, what we know is that we learn minimal amounts of information about obesity as a disease in medical school or throughout our training. So we're supposed to be the shepherds of good care, typically, for this disease that affects 42.4% of US adults, 18.5% of kids, and that was pre-pandemic. And we're just supposed to just ignore it, and then we go treat your diabetes and everything else. We must stop. We must recognize it for the disease that it is, the ability to have significant influence over every organ system, and treat it as the disease that it is. With regards to which tools should we use, I think we should use a variety of tools to see what are factors. If you have significantly larger waist circumference and even have a healthier weight, let's say you fall into a category of having overweight, that's still problematic. We could still maybe consider the use of medications, which we can begin to use at a BMI of 27, for example. But we have to look at the whole picture, and we have to individualize and personalize care for the patient that's sitting in front of us at that very moment.
I think that's your last point, is one of the most important as well. It's about an individualized approach, right? Oftentimes we hear this worked for my friend, or I saw this individual that lost weight this way. And we're looking for one size fits all. Ms. Calicutt, I see you saying yes. Can you talk a little bit about that? I'm sure during your journey, you may have individuals who saw your success and wanted to do exactly what you were doing. How do you counsel your friends and family as you go on your own personal journey?
Well, real quick, I wanted to touch on something that Dr. Cody Stanford said. I think that there is still a lot of bias when it comes to obesity care and management. The fact that lower BMI patients have to have a real disease, they have to have diabetes or high blood pressure to even qualify for surgery or medication, still lets you know that obesity is not seen as the disease that it is. And I think that the 6-month weight requirement for weight loss and doing this and having to go to all these meetings, you don't have to do that for anything else. If I wanted to get implants, no one would tell me, well, try these on for 6 months. We're going to give you these saline bags and walk around the world and see how you feel and then come back to us. With seeking help for obesity, it's like, okay, well, my car is broke. Well, did you try to fix it first? I tried, but I'm not the expert. Well, you need to try to fix it first, but my car is broken. And I think that a lot of these barriers in place are related to the stigma and bias of obesity. But getting back to your question, Dr. Knight, I tell people that what works for me might not work for you. I am able to go to the gym and weight train. I don't actually do a lot of cardio. Some people need that. Some people don't. I follow generally a lower carb lifestyle. One of my friends can't eat any fats. It makes her sick. So it is very important that care is individualized for everyone across the board. I'm going to go back a little bit. When I was 16, I grew up in the Kate Moss era. Everybody was thin. It was Ally McBeal, a lot of waifs. And as somebody who's always been bigger, I'm a big person. I had a diet that went a little bit too far, and you could see my ribs. And my mom, she took me to the pediatrician, and the pediatrician plopped me on the scale and looked at the number on the scale and said, I don't see what the problem is, she's fine. But I actually wasn't. So I think that now I might receive a little bit different care, but it's just looking at all the factors for an individual when coming up with any sort of treatment plan or maintenance plan. That's what we got to do that.
Thank you so much for that, and for sharing some of your experience. This is the reality for so many people on all ends of the spectrum. You know, when you talk about your experience as a pediatrician, that is a good question about the kind of education that our providers are receiving when it comes to obesity and weight management, and maybe even how are we testing physicians with regard to that. And I'm going to go back to Dr. Stanford, obviously, as we know, very well published, and one of her recent articles talks about evaluation with regard to knowledge and obesity that we see in practice for clinicians. Can you talk a little bit about that, Dr. Stanford?
Absolutely. And so this is very timely because I did not necessarily time when this article came out, and none other than our Journal of the National Medical Association and this actual talk that we're having. But I had a piece that just came out where I looked at all of the American Board of Medical Specialties, meaning all the specialties that physicians can train in, to see how well we were testing individuals in pediatrics or OBGYN or surgery or pathology about the disease of obesity. And what we found by looking at the content outlines of all of the 23 of the 24 American Board specialties is that obesity is very infrequently taught, or not taught, is not a specification that receives significant consideration. For physicians, when we go and learn material, we learn what we need to learn based upon what's on the exam. If it's not being tested, it must not be important. So that's really, really important. Now, when we think about that work, that complements some previous work that I published just a year and a half ago in the International Journal of Obesity, where I looked at a systematic review of what medical students, residents, and fellow physicians are learning throughout the entire world about obesity. And it's unfortunate. We usually could say, oh, they're doing a good job in Sweden, or, oh, wow, over there, in Japan, they're doing a great job. No country in the entire world is doing a stellar job based upon that review of every country of educating medical students, residents, and fellow physicians about the disease of obesity, despite the fact that it's the most prevalent chronic disease, not only in the US, but around the world. So it's this constant thing that we see. Poor education of the people that are supposed to deliver care here in the US and around the world, which means that there's limited access to those of us that can provide the level of care that we are talking about this evening.
Thank you, Dr. Stanford. And Dr. Johnson, can you talk a little bit about maybe some of the work you're doing down there in Atlanta to increase education around obesity for our current and future clinicians?
Right, so I teach residents and students as a part of the medical school. I'm the program director for our residency program. And so we ensure that our residents are exposed to the field of obesity medicine, bariatric surgery, and not just the surgery, but how to take care of the whole patient and what that entails. Now, in the community, the Georgia chapter of the American Society of Metabolic and Bariatric Surgeons has been working tirelessly to afford access to obesity care for our state employees. So Georgia is one of only 6 states in the United States that does not have access for state employees to bariatric surgery as far as insurance coverage. So our teachers, bus drivers, and other state employees would need to pay out of pocket for these benefits. And we've already talked about the benefits are not just treating obesity, but the diseases that are related to obesity and even preventing cancer down the road. And we have seen some very interesting and exciting early results of cancer prevention, with obesity treatment and bariatric surgery. So it is really, really a pressing issue. And we've been working very, very, very hard on making sure that we give the best access to care for everybody in the community.
Thank you so much, Dr. Johnson. Ms. Calicutt, I wanted to bring you in here because one of the things that, our medical history is personal. It's private information. And oftentimes there is sometimes a stigma, not only of excess weight, but of having medical or surgical treatments to treat obesity. We know these days, I think people are a lot more free in talking about procedures they may have had or interventions. But, 10, 20 years ago, no one would talk. They kind of just go away and come back and you just had a really good diet. So can you talk a little bit about that, that stigma, not only around excess weight, but of actually utilizing medical and surgical interventions?
It comes right back full circle to somewhere we still believe that this is a disease of willpower. It's not a disease, actually. It's you've done it to yourself. You deserve everything that happens. And when you've internalized all of those messages that you've received your entire life, there's a lot of shame associated with that. And you don't want to talk about how you failed. You don't want to address that at all. And as we move forward, changing the narrative about obesity, I believe that we will see a lot more people opening up about the treatments that they've had. In the same way that we talk freely about chemotherapy or radiation or, other chronic relapsing diseases. But it's hard. It is. It's really, really hard, especially in our community. There is a distrust of medical providers, even medical providers that look just like us. So we need more advocates. I don't know that there's a whole bunch of me. And I've reached out to other contacts. And if we can't find them, I think we need to make them. We need an advocate academy.
Thank you. And of course, yes, I agree with you. We need more people on the front lines that are advocating, particularly around this, because it's affecting so many people. And unless we come together and do it in an organized fashion, we're going to continue to fight against this issue. Dr. Stanford, I have a question for you. You have also done a TEDx talk and talking about some of the interactions between COVID-19, obesity, and also racism, which we know has been a barrier and one of the root causes to continued disparities in healthcare. Can you talk a little bit about that?
Yes, well, Dr. Knight, I'm so wonderful being prolific and knowledgeable about this recent TEDx talk. But no, with all joking aside, I really wanted to talk in this TEDx talk that I just gave just a week or so ago about the collision of those three pandemics that Dr. Knight mentioned. The collision of obesity, which has been here, which has been largely ignored, as noted by my colleagues, Dr. Johnson, Dr. Knight, and Ms. Calicutt. COVID-19, which, like I said, has affected us, and then, of course, racism. Let's go to this COVID-19 issue. We spent a little bit of time talking about it. So we talked about obesity as a disease. Obesity is also a disease that's characterized by chronic inflammation. Okay, so this chronic inflammation does not interact well with the acute inflammation that comes about with a COVID-19 infection. They don't play well at the playground together. As such, we saw back last summer when we first were dealing with COVID, initially the Centers for Disease Control and Prevention put obesity, severe obesity, as a major risk factor for inpatient hospitalization, ventilator use, and dying. But then they broadened it and they included all of obesity as they began to study a little bit closer. So much so that for vaccine distribution, as we were looking at vaccine distribution, we saw that persons that had obesity were given significant consideration, earlier movement to the beginning of the line behind healthcare workers because of the risk of both sickness and dying. So we've had the collision of these three things that have really been magnified in front of us. And I think that patients are beginning to get the answer. So our wait list, for example, to be seen at our weight center post this pandemic, or I don't know if you want to call it post or in the middle or what we're going to call it, is, we have an excess of 700 patients waiting to be seen. As people have decided, wait a minute, this obesity, they keep saying it's a disease. There's this COVID thing. It seems a little scary. I need to take care of it. But let's add that third piece, racism. What we do know is that the two most common forms of bias in the United States are race bias, which is playing out on our TV as we see the monumental, charges against Chauvin play out, where he was actually found guilty on all three counts. And we saw that rise during the middle of this pandemic. The murders of George Floyd, Ahmaud Arbery, Breonna Taylor, amongst many others, play out in front of our eyes. And so these three things have interacted in such a way that we've seen just a collision. And we know that when you have three cars running into each other, it doesn't lead itself to a good outcome. So that's what I really wanted to capture, in that talk. But what hopefully you guys understand is we're looking and you think about maybe family or friends who you've unfortunately lost to COVID, and maybe the higher likelihood of you seeing obesity within that group. And then it's seeing it disproportionately impact BIPOC, or Black, Indigenous people of color in the United States. So hopefully, Dr. Knight, that kind of gives a sense of what I was thinking about and how I think about the collision of these three pandemics.
All right. Thank you, Dr. Stanford. And I love the way that we talk about intersectionality with a lot of the pandemics. And unfortunately, our community has been dealing with a pandemic of racism for quite some time. As we get ready to close our program, we want to remind folks in the audience, if you have any final questions, please put that up. We have one question that's come in from Ms. Calicutt, speaking about any encouragement or advice you would give someone who has been battling obesity and is afraid to seek help.
Seek help. Lose the shame. It's not about you. It is not a personal failure. If you broke your arm, you would go seek out a physician. You would go seek a medical care team. You would have a whole army behind you to make sure that that arm got better. And it's the exact same way that we need to face obesity. And you can also reach out to me.
Thank you, Ms. Calicutt, for that. And as you said, seek help. I think that's the biggest piece here. There is help available. There's treatment available. If you've been wondering why that diet has not been successful, why you have been battling it, don't do it on your own. Utilize the resources that are available to you. And speaking of resources, Dr. Stanford, if someone wants to find a obesity medicine specialist, where can they go to find one?
That is a great question. I think the best resource to find people like the three of us that you see tonight is go to the American Board of Obesity Medicine site. This is freely accessible for anyone to go. Right now, you can go to, it's called abom.org or American Board of Obesity Medicine. And in the top right corner or somewhere in that general area, I'm not looking at the site right now, there's a place to find a physician. You can actually go and search for physicians by zip code. So for example, Dr. Johnson is in my hometown of the ATL. And so she might be near my zip code that I grew up in, 30331 in Southwest Atlanta. So you might find Dr. Johnson. Whereas if you did a search in the DC area, particularly around the Capitol, maybe you'd find Dr. Knight, who's here. And then for myself in the Boston area, you would find me, but you'd find those that are certified. We now have over 5,000 physicians in the country that are board certified in obesity medicine that can help you navigate this disease of obesity. And we're here, we're armed, and we're ready to help because we want more success stories like Miss Calicutt, who's able to come out here, serve as an advocate and tell you, look, it's not your fault. You would go get that arm fixed, and we want you to get that arm fixed, but this is even more important.
Mm-hmm.
Exactly. And I see a comment in the chat about registered dietitians. I know I speak for myself and likely all of the other clinicians on the call that we work in partnership with dietitians and that are part of any comprehensive weight management program is going to have dietary support. I know there are some physicians who have dietary training or nutrition training, as many of us do, but I still work with our dietitians because those are critically important. In there. And so what we want to do as we wrap, we want to again thank our panelists for being with us tonight. We can get their social media handles up there as well, because if you want to connect with Ms. Calicutt, Dr. Stanford, Dr. Johnson, you can find them on social media. You can also reach out to us at NMA, National Medical Association, to get our information and to talk to us. We're bringing you directly from leaders in African American health to talk about issues affecting the African American community. And so again, I want to thank Dr. Fatima Cody Stanford, Dr. Shaneeta Johnson, Ms. Kesha Calicutt. We want to thank the NMA Talks production team, Dr. Shonda Holsley, as well as Ms. Jennifer Young, who has worked very hard in the background to put this program together. So until next time, please stay safe, be healthy, and let's continue to work to achieve equity for health in our community. Have a good night.
Thank you.
Thank you.